Okay, so now we have a Q&A session. For those of you joining online, you can type in questions into the chat, and then we will answer them. If people have questions here, raise your hand, and we have a microphone that we can pass around. Okay, and I'll start us off, actually. So for Dr. Buckner, if you have a patient with heavy menstrual bleeding and low ferritin, but they're not anemic, do you go straight to IV iron?
Thanks for the question, Lisa. I think we used to have trouble treating iron deficiency that had not yet progressed to anemia. I think my experience more recently is that insurance companies are more willing to approve of IV iron, and so we don't have that as big a barrier, though that still remains a barrier for many patients. So if that is an option, I think we do often go straight to IV iron. The infusions are safe, they're very effective, they work quickly. We always offer oral iron. Many of our patients, by the time they get to us, have already tried that and experienced side effects that limit its use. So we are jumping to IV iron fairly frequently, I would say.
Just to kind of follow up on that, I guess two-part. One, both of these are related to your first abstract with the heavy menstrual bleeding. So first, do you know, and I may have missed it, did they screen for an underlying bleeding disorder? And kind of a follow-up to that, for women with heavy menstrual bleeding, should we be screening? Should we get von Willebrand or?
So you're asking about the combined
Right.
contraceptive and TXA?
Patients who were enrolled potentially had like a mild type 1 von Willebrand disease.
Yeah. So for that abstract, they all had von Willebrand disease.
They did? Okay.
Yeah. So under 21, female sex assigned at birth with von Willebrand disease. And so should you screen for bleeding disorders in someone with heavy periods? Yes. And I think the standard, depending on what other bleeding symptoms they have, kind of determines to what depth you take the screening tests looking for a bleeding disorder. But even isolated heavy menstrual bleeding, particularly if it's not responding to hormonal type treatments, I think screening for von Willebrand disease is a good place to start.
So do you think that is applicable? The combination is applicable to women without von Willebrand then, that have heavy menstrual bleeding?
I think so. There aren't a lot of safety data in any of these populations, but I think my experience, even if you haven't diagnosed a bleeding disorder, is that adding tranexamic acid during the menstrual period for someone on contraceptives is okay. We certainly do that without much fear of a markedly increased risk.
We'll figure out the mic. I was another one for Tyler, and interesting that the synergy on this question may be between your field and myeloma. But you mentioned the pomalidomide for hereditary telangiectasias. What's the sort of mechanism thought to be effective there? Is that known?
I don't know. I would assume it has something to do with the angiogenesis and the defects that actually lead to the telangiectatic lesions. I'm not sure why. I don't think it's known at all why it would potentially have a differential effect on nosebleeds or epistaxis versus GI bleeding. But the very specifics of why POM works in HHT is unknown to me.
And Jorge, where is the field in sort of the lenalidomide derivatives in myeloma? Has there anything happened there in the recent past?
So now there's a new family of what you would call thalidomide analogs. They're called CELMoDs, being manufactured by the same company. Much more effective, much better tolerated. We're opening a trial with one of them called mezigdomide on 1 to 3 prior lines of therapy. It's going to be a phase 3 randomized trial. They're really easy to use. Still get some cytopenias, just like you get with Revlimid and Pomalyst, but much more efficacy, much more potent. So I think that as time goes by and those therapies start to lose their patents, right? Like we're going to start to move them earlier and earlier. There's already clinical trials using the CELMoDs in, not just in newly diagnosed myeloma, but also in precursor disorders. And I think that at the end of the day, we're gonna be replacing them, right? Very similar to why we don't use thalidomide here in the US. It's not just because of the birth defects, because we're very good at doing the whole pregnancy testing beforehand, but because it's better tolerated, that Revlimid is better tolerated than thalidomide, and you don't get the peripheral neuropathy that frequently. Maybe the only advantage that thalidomide has is, well, number one, the cost, obviously, so it's used a ton in other countries, but thalidomide also causes a lot less cytopenias, so maybe in one of those patients where the cytopenias is being an issue, and neuropathy isn't, then thalidomide might be a good idea, but the Europeans have much more experience with that.
And one more time, can you just describe the study that you'll be opening with this new agent here?
With mezigdomide?
Yeah.
It's a phase 3 trial comparing mezigdomide to, I believe, so it's mezi, bortezomib and dexamethasone against pomalidomide, bortezomib and dexamethasone. Phase 3, 1 to 3 prior lines of therapy.
Great. Yep. Thanks.
We have another question online, and a kind of two-part question. The first thing is, like, what risk score do you use to identify patients with smoldering myeloma as high risk? And then secondarily, I think you had talked about starting daratumumab for higher risk smoldering. How has that experience been?
So the risk calculator I use is the one that the IMWG developed, and you can go online and just search for it, and you'll be able to get a better risk stratification than just, is it higher or lower than 20, higher or lower than 2, higher or lower than 20. It will give you a specific score that will also include cytogenetics into it. And then I'm offering daratumumab to everybody with a risk score greater than 9, which are the ones that have a higher than 50% risk of progressing. The experience with starting it has been slow. Like this only came out in December. So we have one patient starting daratumumab because they were very interested in doing everything they could. This is a very young patient, so they are usually more I would say, excited about using something new rather than just watching and waiting, right? Which is not the term I like using. I like using active surveillance, because it like justifies my visit. No? Yeah.
Thank you. So one question to Jorge and one to Tyler. So Jorge, do you think we need dexamethasone for 2 cycle in the frail patients? Because so many patients can't tolerate that, and we could do without it. And to Tyler, some of the young women, their ferritin will be like, say, 50, 60, TSAT is low. It appears they are iron deficient and they are not anemic. And even if the ferritin is a little higher, would you do IV iron?
Okay, so do I actually need any amount of dexamethasone in my frail patients? I don't think we do. The dexamethasone was used in the trial so that we can mitigate the infusion or injection site reactions, right? So that's the main reason why it was added. in my practice, I'm okay doing it for one cycle. And if patients that I don't think will tolerate dexamethasone very well, an alternative is using methylprednisolone. So methylprednisolone has always been part of the daratumumab pre-medication algorithm. And I think that that's safe to use for the first 3 doses. And if there's no infusion reaction, you can just stop it.
It's a great question about iron deficiency and diagnosis. That, especially early iron deficiency, the symptoms can be vague. There are certainly people who have hard to quantify neurocognitive type symptoms or restless leg, et cetera, that do seem to get better with supplementation, though exactly what target for ferritin that we're using is a big point of disagreement, I think. 30 at a minimum for someone who, you're treating iron deficiency, but there are others that advocate for 50 or 75 as a target. Ferritin, as you know, has its own difficulties because it's an acute phase reactant. Anybody with any kind of inflammatory drive will have potentially an elevated ferritin. So I do tend to rely at least sometimes on the serum iron testing, which is best used in a fasting state. So if you can get a fasting serum iron or transferrin saturation, I think that can also reflect iron deficiency, even if the ferritin seems to be in a normal range. So I think if you have a good reason, someone is having heavy periods, they have at least one test that's consistent, and low saturation of transferrin is a fairly specific diagnostic test for iron deficiency. I think that would justify treating the iron, and then of course following and seeing, does it recur? Does it, what does the ferritin do afterwards? While at the same time, you're treating their heavy periods. I think yes, we would still treat that. Would you get IV iron approved? Sometimes that's up in the air, but you can at least start with oral iron and document response and go from there.
Okay, thank you very much to Dr. Buckner and Dr. Monge. We have a break now, so please enjoy coffee and snacks, and also please visit the exhibit room. And I think we'll reconvene around 9:45-ish.